Alrighty, everyone. Good evening again, and welcome to our MES Masters Training Series. Now, folks, this is what this is all about. It's all about presenting your most challenging clients. This is not a class. This is not a training. This is a forum for medical exercise professionals from around the world, as well as medical professionals, to come together and present their most challenging clients. And folks, in the medical community, this is commonplace because we've learned that one brain doesn't have the capacity of 4 or 5 brains in the room that all have the same training, because they can look at things from different viewpoints. And one of the things I realized in our advanced medical exercise specialists, we wanted to make sure that our students were looking at the clients globally when they came in for medical exercise training. Make sure they took into account the medications the client was on, looking at what their medical history was. So this Masters Training Series is going to give everyone a chance to present a challenging client. You don't have to if you don't want to, but I think what this is going to do is allow us to look more with more depth at what's going on with our clients, and by seeing what other medical exercise professionals around the world are doing, as well as medical professionals, I think it will give us a better understanding. It'll build our skill set, our knowledge base, and help us establish best practices. So we hope that this Masters Training Series will give you a chance to improve your skill set, look at what others are doing, and most importantly, that we'll share. And I think this idea of medical exercise or medical fitness, whichever one you want to call it, is going to continue to grow, but it's going to continue to grow exponentially well into the 2030s because of what we're seeing with regard to aging, chronic disease, and more importantly, recognition by the medical community now that exercise is important.
Good evening, everyone. Thank you for joining us this evening. Again, my name is Justin Hibbert, and my company is 3 Degrees of Freedom. And for you, I'd like to present my client, John Doe. He is a 40-year-old male who was diagnosed with right hip dysplasia at the age of 17 back in 2001. So the part of the anatomy that's involved with that is the acetabulum, the femoral head, some of the connective tissues in the ilio and pubiofemoral ligaments, as well as the abductor and adductor muscles. For his functional limitations, he's unable to sit for more than 30 minutes. He's unable to walk and stand for more than 45 minutes, again with the job site, and unable to run the bases in softball without pain. Moving into some of the short-term goals that we looked at for his 30 days, what we did was looking at improving his lower extremity muscular endurance, looking to improve his functional capacity. And then for the long-term goals, his 60-day goals, what we wanted to do was, again, continue to increase that functional capacity by sustaining continuous walking and standing for at least an hour without pain, and then also develop a home exercise program for him. Some of the contraindications for him were performing exercises and activities in the pain-free zones. We want to make sure that we did that. And then also, like I mentioned before, avoiding hip flexion greater than 90 degrees and anything with low chairs or seats. For his week 1 program, what we were looking
You can see here we have a right hip. There's the femoral head. There's the acetabulum. You can see this acetabulum is very shallow, very, very shallow. Now, hip dysplasia is very common when I say common, not everyone has it, but it's not uncommon in young people when they start playing sports somewhere between the ages of 10 and maybe 16 or 17. They suddenly will start having hip dislocations or hip soreness. When they go in and shoot an x-ray, lo and behold, guess what? They've got a shallow acetabulum. So that femoral head keeps popping in and out, especially when they're running the bases, turning or pivoting, when the femoral head has to engage and rotate. If there's no depth there, that head pops out and it pops back in, and they may not know it, but suddenly the hip is really sore. They actually put pins in, and what they'll do is go in and cut the bone, shift the acetabulum higher, and put the pins in to stabilize it. So there's the femoral head right there. They've actually moved this bone up. They cut it and moved it up. The term osteotomy, otomy means cut, ostomy means bone. They cut the bone, moved it up, and you can see the 3 pins there. They look literally like bolts. That's what they are. They're there to hold that piece in place, not the whole. So now, one of the things we wanted to do with these assessment procedures was go over those so that you have a better understanding of how they look and what they do. So, Justin, what we're going to do is let's talk about muscle testing. Okay. Some muscle testing.
Dr. Mike, how long have you had the pain?
Ooh. Now, folks, I'm going to play like the client here. You know what? I've had this thing going on, man, since I was probably about in my 20s. This started when I was a kid playing baseball, and I love playing baseball, but my hip kept kind of clicking and popping and stuff. So I don't see anything. Yeah.
Okay. Any numbness or tingling or any issues like that that you
No numbness or tingling, nothing like that.
Okay.
No.
Okay. Awesome. Quick medical history right there, just to have an understanding.
So now, with the medical history, what you're trying to do is just get an idea what went on before, where the client is now, what the client's status is, what makes it better, what makes it worse. Because folks, remember, exercise can be just as traumatic as the injury.
So next what I'm going to look at is your hip flexion, okay? So if you're able to, go ahead and raise your leg for me, right? I'm just going to pull a little pressure here again, don't let me move you. All right, very good.
Now, let me ask the group. He just did the test for hip flexion. What muscle are we testing with hip flexion here? If we had to look at the two muscles, the psoas and the gluteus maximus, which of the two would probably be the weaker of the two? Psoas or gluteus maximus? What do you think?
Gluteus maximus.
Gluteus maximus. So the glute for most.
Okay.
So now let me ask this then. If he had more problem with the internal rotation, did we also see weakness in his hip adductors?
Yes, we did.
Okay.
Yes, we did.
Now, here's the deal, folks. I adduct my hip. When I adduct my hip, obviously the adductors are involved. This also gives a degree of internal rotation. So there's a pattern. If I have weak internal rotators, I'm probably going to have weak adductors also. If I have weak adductors, I probably will also have a weak quadricep down the road too.
So I'll have you bend your knee for me right here, all right? And then I'm going to have you go ahead and lift your foot straight up, and then I'm going to let you stay here. I'm going to push down and don't let me move you. Right, and we're going to keep the left leg straight. Now, if you would, I want you to go ahead and lift up your right leg for me. All right, thank you. And then stay right here in this position. I'm going to put a little downward pressure. Don't let me move you. Okay, come back down. All right, good. Now, if you would again, go ahead and bring that up for me. All right, I'm going to put a little bit downward pressure just right in here with the left hand. Very good. Okay, and relax. Nice.
Okay, he needs another surgery. So here's the question. This is the moral dilemma for you guys. Do you train him when he comes back for a short period with the requirement you've got to go see the physician, therapist, or chiropractor? Or do you say, hey, I'll train you, we'll just see what happens? Or do you say absolutely no? What do you think? Okay. This is why we're having this master series, just to get you to start thinking, you know, what's the best thing to do with this client? At some point down the road, he's going to have to pay the piper and he's going to have another surgery. Now, him playing softball isn't going to significantly make him worse. It will just speed up the process. So when he comes back, I would say, you know what? Before I train you, you need to go see an orthopedist about this.
Yep.
And before I do anything with you, see the orthopedist, bring me some type of report back so I can make sure that you're appropriate for exercise. Because all we're going to do is make them worse.